Welcome to the Long Story Longer podcast.
I'm Dominic Marano. I prescribe meds.
And I'm Katie Brzozowski, and I provide psychotherapy.
Long Story Longer is a podcast about mental health and navigating medication, therapy, and whatever else we want to talk about.
We will discuss topics from each of our perspectives. We will try to keep it to 15 minutes.
But it will probably be longer. Hello and welcome to the Long Story Longer podcast. My name is Dominic Marano. I am a family and psychiatric mental health nurse practitioner. I own my own psychiatric practice and I have a doctorate in the nursing practice. I've been in healthcare for over 20 years and more recently into mental health.
Hey, I'm Katie Brzozowski and I'm a licensed clinical social worker and I have a doctorate in clinical social work and I own a private practice and I've been in the mental health profession for over 25 years.
Hey, so today we wanted to talk about unipolar depression. Previously, we had discussed bipolar depression, which consists of unipolar depression and mania, but today we wanted to talk about just unipolar depression, as a lot of our clients come in with it, and there's a lot of interesting information and interesting treatment involved in unipolar depression.
The term unipolar depression, that seems like something that not a lot of people use, but it just means depression, right?
Yeah, just straightforward depression. But I think, why I mentioned bipolar depression is because there's two directions in that. You either go up or you go down. And in unipolar, it's just one direction, and that's down. So I think unipolar depression and just depression in general are commonly used interchangeably. There are a number of common misconceptions about depression. Sometimes people will only associate you're only depressed if you're suicidal, or some people will say, oh, I'm just really sad, but I'm not depressed. There's a difference between being sad and depressed.
So some statistics about unipolar depression, again, also referred to as major depressive disorder, MDD. Approximately 8.4% of adults in the United States experience a major depressive episode each year. That means about 21 million individuals.
Young adults ages,
yeah, you do it.
Young adults ages 18 to 25 are the highest demographic experiencing depression.
Okay, and gender, more common in women than men. In the U.S., 10% of adult females and 6% of adult males report having a major depressive episode.
And there's a 40% chance of having another episode after your initial episode. So getting into signs and symptoms, Katie, do you want to go into the core symptoms of depression?
Sure. And first, I do want to say that, like, I think you had already mentioned that it's not just sad. Depression is not just sad. And you can be sad and you can even be depressed. People are depressed. That doesn't mean you have depression, just like we've talked about in some of the other episodes. But depression, we have to look at the signs and symptoms. They have to be ongoing for at least 3 weeks. And it has to impair your life in some way. So someone who's just really upset about stuff, and life's pretty stressful and can make you pretty sad, things happen, but we want to look at a huge impact on your functioning for a sustained amount of time. Persistent sadness, loss of interest, fatigue, negative thought patterns, rumination. You might withdraw from social activities, reduce self-care. You might see people, they stop showering as much, or they just stop. Everything becomes harder.
And then some people get a little confused about what rumination is. Rumination versus obsession. So I think rumination is like having the same thought over and over again. I'm not good enough. People don't like me. And then versus obsession, which can be a number of different things where that's all you think about and going really hard at it. They're very similar, but I think there's a little bit of difference between them.
That's a good point to make that distinction.
Yeah, like rumination usually goes with a theme and obsession is with an exact thing.
Yes, I leave the light on?
Yeah, or no, I don't have
That's
another
a
example.
bad example. We're both bad examples. Okay.
Yeah. So, we'll just leave it at that.
Yeah.
There are also, from a physical symptoms perspective, one of the major symptoms that people experience are sleep disturbances. That's the number one that I look at. If someone's sleep is improved, do they feel better versus it's kind of like the chicken or the egg. They're sad or depressed and they can't sleep, and one feeds into one another.
And is it sleep too much or too little, or either one?
It's either one. It's more common to have more sleep in depression because you kind of think of it as depression or a slowing down of things, a really like instead of being excitable, you're on the opposite end of that. But some people who are depressed, if they're thinking dark thoughts or things of that nature, don't sleep, can't sleep. Another thing is appetite changes. I think appetite's super interesting in mental health because there are your depressed or anxious people who eat a whole lot.
Hmm.
And then there are people who don't eat at all.
Yeah. Do you see a trend either way?
Usually people who are depressed will eat more.
Mhm.
And as you're depressed, you can also put on weight as well because people typically don't do much. I think of it depression as kind of like a slowing down of things that interferes with life because you're not as productive as you normally would be. Sometimes there can be comorbid conditions. Again, these are things like substance use. Things if you're using downers can influence your mood, and being off of those items too can certainly make your mood worse as well, depressed in that form. And then having depression and anxiety, sometimes it's super difficult to tell, is this depression or is this anxiety, because there is an overlap of those symptoms. Sometimes people feel restlessness, which you would associate with anxiety more
Right.
commonly, but can occur in a depression. So we use various tools and diagnostic criteria. Using the DSM, there's a number of different criteria within there. Some of the things you've already talked about, the scoring system, if you will, to determine if someone's mild, moderate, or severe. And then I use the PHQ-9 for everyone I see initially
Okay.
as a scoring system. And then
The
you
Beck Depression Inventory, that's a big one
yeah,
too. That
yeah.
people
There's a
use.
number of ones, whichever one you like. It's like you start with that one, you stick with that one. Is my big thing. And then really, like I used to like to use those tools to see where we start and where we end up. And then, as we talked about before, there's sometimes the symptoms are so severe that you may require medication or psychiatric intervention or even therapy. So a lot of times, if people will ask what to do, is if this is interfering with your life, I think some sort of intervention is required.
And my understanding is that, and I think there are cases, I think, where just therapy would work or just medication would work, but it is the best to have both on board
They pair very
at the same
nicely.
time.
Yeah,
Yes.
they pair very nicely, and there's neither are superior to one another. We just know they both work very well together.
One of the questions I get asked often is where's depression come from? So like, is it from an event or a situation, or is it, just does it come out of the blue? I would say what the answer to me is either one. Would you agree with that?
Yeah, I think my philosophy, as I beat to death on this thing, is that there are three areas of what affect our mental health: our neurotransmitters, and neurotransmitters are responsible for a lot of mood. Some people will respond to just antidepressants alone. That's likely to mean that there was a neurochemical situation going on, whether it be too much or too little of certain chemicals. Then it's what's happened in life. If people have had trauma or events happened in the past that caused them to be sad. And then it's what situations are going on. Something
Yeah.
could tip the scale to where stress in and of itself can be a cause of depression. So if you're in acute stress and it worsens your baseline mood, then you can enter a depressive sort of state or time.
And when I worked in the cancer center, often they would prescribe antidepressants to people who were now having symptoms of depression and did not have any depressive symptoms or episodes prior to their cancer diagnosis. It really did cause an actual clinical depression that was treatable by medication.
Yeah, and I think that we had talked about that before, that physical health, physical mind health, the mind body connection is so important. So it would be understandable that while someone's experiencing a cancer diagnosis where their body is really just taking a toll and having to go through treatment and really just even just having the diagnosis, knowing that you have it, that can certainly be, something that will bring the mood down for sure. So in terms of specific therapies, is there anything that you would recommend for anyone with depression?
Yes, there are three primary evidence-based therapies that are often used for clients with unipolar depression, and that would be CBT, DBT, and ACT. So CBT is cognitive behavioral therapy. DBT is dialectical behavioral therapy. I believe we talked about that in our episode on bipolar disorder and borderline personality disorder. And then ACT, which is acceptance and commitment therapy. That's the only one that doesn't go by ACT. It's just called ACT. The other ones are not.
Unless you're me and I just call it ACT.
Oh, that's fine. I think I was corrected at one time, which now I'm like vigilant about not saying it wrong. I use ACT more than I use the other two, and that is because I find it to be more effective. Certainly CBT is very effective. This is not anything against CBT, because obviously a gold standard for treating depression in therapy. And I always recommend Feeling Good, which is David Byrne's book, which is the Great Layperson book. I think you've read that
I have.
too.
I love that book.
It's very helpful.
It
And
is. I think you had mentioned it at the time. These therapies in themselves are. I'm a very logical minded person where I think could easily identify things that I was doing that were contributing to depression or challenging my thoughts that didn't gel with reality.
that right, and that is why CBT is very helpful, but why it doesn't work all the time, which is why I ended up switching more to ACT. And that CBT does exactly that. It points out, well, there's lots of different parts of it, but one of the things, it's the chain is, did we talk about this in a different episode? We did. Yeah, okay. So, well, if they didn't listen to the other ones.
That's okay. Say
So basically, the premise of CBT is that we have a thought and that affects our mood and behavior. So our place to change it then is to change how we're thinking of something. And that's great if it is a distorted thought, if we are personalizing, or if we're catastrophizing, or if we're doing black or white thinking. And that's often, having those kinds of thoughts are what keep us stuck in a depression, or can help add to the depression. But not everything is a distorted thought. So when I see a lot of people for grief and loss, or at retirement, older adults, retirement age, different things, a lot of the things that they're presenting are not distorted. If they're saying, like, I no longer have an identity with work, or I no longer have a place to go, I'm not important to that place anymore, that's not really a distorted thought. It's true. That's accurate. Maybe they're not that they're not important, but as far as that's a reality. And so in that case, trying to change those thoughts just doesn't make sense. So that's why ACT is, to me, more effective in certain circumstances, because it doesn't try to get you to change the thought. It gets you to pretty much accept the thought, and just to make it background noise, and then focus on your values. And then DBT, like we've talked about before, it's very it's also behavioral based, and it helps with managing emotional regulation and skill building, and then also some mindfulness components. And there's also some creative therapies, art therapy, music therapy. Those can be used often with depression. But if you do have depression and you are going to a therapist, I would find out what they use, and because that lens is going to matter. Because if they only use CBT and you're facing a tragic loss in your life, that might not be the best way to go.
Yeah, and I think that you hit the nail on the head with that each therapy may be more useful for depending upon the person. For instance, like I said, I'm a logical person most of the time, and that for me, identifying what wasn't making sense in my thought process was useful. And for DBT, people who I have patients who are like, I don't know how I feel, but on paper, their scores are like, yeah, you're severely depressed. So just managing emotional regulation.
Dom, why don't you tell us a little bit about medications?
There are a lot of medication options for unipolar depression. And as I say to a lot of my patients, a lot of it is just a crapshoot. You pick one, see if it works, and see if you can tolerate side effect profiles too. The three options that are usually described are selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, which are SNRIs, and atypical antidepressants, which consist of a few medications that, again, atypical just means not the standard treatment, and they work on various neurotransmitters. So these medications actually work by balancing neurotransmitters. Sometimes there can be, by giving a medication, you upregulate neurotransmitter production, or by giving a medication, it calms down the neurotransmitter production to a level that would improve depression.
The way that I would explain that to clients is, I would say that there's like a depression fog. Like, a depression will make like this fog in your head, and an antidepressant or any type of medication is not going to make your situation or your problems or anything go away, but it's going to lift the fog a little bit, so you can kind of see things a little more clearly, and then function better.
That's a fair perspective as a psychotherapist, for sure. Sometimes I do have people who just take medications and then they get better. So I think that for some people it is solely a neurotransmitter issue, but for a vast majority of people it's going to be a combination of requiring therapy, requiring medications, and we're learning that might even be more neurotransmitters involved in depression, as there's been newer drugs out that are working on glutamate pathways. New research will come out that, or new drugs will be developed that look at glutamate regulation as an option. And now they're using some of those medications for treatment resistant depression, because since they are new, they are more expensive. So, and again, can certainly come with a side effect profile. Some of the common side effects, just by class, the SSRIs, for anyone who's taking a medication, I like to look at the three big things why they're not going to take a medication. One, it's going to worsen suicidal ideation. So someone who's having suicidal thoughts initially, they may uptick or they may get better. But if they uptick to a place of intent, you would not want to take that medication. The second is weight gain. A lot of medications can cause weight gain. Some of the medications for depression don't actually cause weight gain, but for those people, when they're depressed, they don't eat. You cure the depression, and then the hunger comes back.
That is an excellent point.
And then sometimes there can be sexual side effects. A lot of times for young men, they're not going to want that. Or even young women. More so young men. More so young men will be like, I don't want anything that does that. But there are a number of different medications that don't influence that. Some other common side effects. Some medications will keep people awake. So insomnia is a common side effect. Now, sometimes that can be temporary, but we'll get into just how to address side effects in just a minute. And then the last side effect that I'm thinking of, there's also dry mouth. A lot of the medications can cause dry mouth. Others are a little more complex, but they can influence your sodium levels. Usually the SSRIs are the culprits in that, where they'll bring your sodium down. So we do like to check labs with that. In terms of addressing the side effects and managing expectations, I think that some side effects are going to be temporary. So for instance, if you start taking a medication, so let's use bupropion as an example. This is a medication that gives a lot of people motivation, gives them a lot of energy, can help with focus even, but a lot of people get a jazzed up energy for it. So if you have an underlying anxiety and now you have energy that just came from a medication, but feels like it came out of nowhere, you can feel a little restless or a little uneasy at first.
Does that ever get misdiagnosed as mania?
So mania, that's a good point. That's a big side effect of some of the medications. We should cover that one. But mania, so yes, people who have, now remember, we're talking about unipolar depression now, but people who have bipolar depression, if you're undiagnosed with bipolar disorder and you take an SSRI or SNRI, sometimes people can experience mania. So mania is described as a drastic shift in energy on the uptick, where people can be impulsive, they can have racing thoughts, have a very low need for sleep. So that's a major side effect for sure. But that would be different than having just a transient elevation in energy or a transient restlessness. I usually tell people try and ride it out for 1 to 2 weeks. Typically speaking, most medication side effects happen in the beginning. At least the ones that you'll notice that would be problematic for side effect tolerance. And if you can wait that out, sometimes they'll level out, sometimes they don't. And if they don't, then we can cancel the medication and try something else. But the idea is that you wait it out a little bit. We are playing with brain chemicals. They do impact your physical health as well. So in terms of expectations of medication, it takes a full 6 to 8 weeks to achieve full efficacy of a medication, an antidepressant, or at that dosing, to get the biggest effect from it. You're going to have that 6 to 8 weeks where we've changed all that we can change now, and that's where you're going to land. So I usually tell people to wait about 2 months before we consider either dose adjustment or changing the medication. And that's kind of like, are you going to be perfectly cured from depression? No, but is life better? Are your thoughts better? Is your functionality better? So in terms of medication alone, I think it's just a watch and wait thing, very slow. That's why I do recommend concurrent therapy. Sometimes I will tell people, and I don't know how true this is, but I do believe it myself. But when you go into therapy, you might have stuff packed away very neatly that now you're pulling out, so your depression may get a little worse.
Oh, yes. Yep. Yes, that's true.
Yeah, so some people, it's hard to tell, and it's with medication, the timing of things, you just make sure you're like, I always say, well, are you unpacking a lot in therapy? Mm-hmm. And people say yes, and then we'll wait and give it a little bit longer. But a realistic expectation is that it's going to take time. And all medications are capable of having side effects. For instance, the simple one of dry mouth I tell people is, if your mood is that much better, if you are less suicidal, if the way is that you have dry mouth, then suck on some sugar-free candy, drink plenty of water. Yes. Water's good for everyone. So I think that I recommend that to everybody. But I think the idea is does the side effect cause you more harm than good, or more harm than benefit?
And it may not last forever. Also, like you said, I also do encourage my clients to stick with the medication through the side effects if possible. Obviously, if it's very severe, and to make sure they report side effects that are concerning to the prescriber. But I don't like when people are just like after a day, like, oh, I don't feel good on, I'm changing it, because it's a long road to keep switching and switching and switching when maybe that first one would have been a perfectly fine medication. Sometimes when I get clients, I'll start assessing in my head that maybe they need medication, right? And then they'll say, I've been on, well, I take Lexapro or something. And I'll say, okay, well, how long have you been taking it? And they'll say like 15 years. And so, okay, that's great. But maybe it should be reevaluated. Maybe you need a different dose. Maybe you need, a different medication or additional medication, because you're taking that for your normal situation. But when you have a new crisis or something, I feel like sometimes it's not, doesn't always work that same way.
Yeah, so two thoughts on that. One is there is called poop out syndrome, where the antidepressant just doesn't work anymore. So
Okay.
that can happen after some time of a medication where either your body just acclimates to it and it doesn't have the same effect, or were there biochemistry changes that happened in your body. Your bodies change over time. People have babies. Different things happen where it can change our the way in which our bodies work.
That is very important.
Yeah, super
Yes.
important. The other thing is that you mentioned it, and I will tether onto this, that there are augmenting therapies. So sometimes we add on medications like atypical antipsychotic medications, and everyone usually gets scared with that, but we add them onto antidepressants to help bolster them. Abilify was marketed initially as, and the name sounds like it sounds like it's enhancing the antidepressant. You're now able to not experience depression because we're doing that. There's Rexulti is another one that we add on to that. So these are just some of the more common augmenting therapies. A lot of them, again, are just supposed to bolster the effects of the antidepressant. I don't want anyone on any medication that isn't doing anything, because why?
Yes.
Why would
Yes.
you be on something that can cause a side effect, can interact with other medications, and who wants to take any additional pill they don't have to take?
I see that often. People will like finally agree to go on an antidepressant, or they've been on an antidepressant, but they are very resistant to increasing the dose. I try to encourage them to talk about their dose with their physician, because maybe you're not on the therapeutic dose. Like they start off, don't you start people off for tolerance, right?
Yeah, yeah. There's starting doses for a standard population and then starting doses for special populations. For instance, the elderly or children,
Okay.
or people who have kidney impairment or liver dysfunction or things along those lines. But yes, the idea is to start off to make sure someone can tolerate the medication. And then if they can, great. But if they're still not at goal with medication, which would be to reduce depressive symptoms, then you would go up on the medication because they may need a higher dosing.
From my perspective, I do end up seeing a lot of people that just don't want to increase it, because for some reason it feels like they just don't want to go up. They're already taking it, they don't want to go up. And I try to also like you encourage them that if you're going to take it, you might as well take something that's effective. Why take it if it's not working, if it's
Yeah.
not the right dose?
Yeah, and just commenting on the last, for treatment resistant depression, there are a number of different medications that we use. One is intranasal esketamine. That's for refractory depression. You have to have two failed antidepressants at least. And there's a number of different preclusions from that. So we don't have to get into all of them, but just know that standard medication is fine. Augmentation therapy helps with standard therapy, and then there's for treatment resistant depression. That's the third tier of therapies that people use.
Okay.
So there is an oral agent that just came out recently that is paired up with something that's in cough syrup, and it's showing remarkable results. But for new medications, they're so expensive, and it's a challenge to get them from insurance companies. But usually there are like hardship lines and stuff with companies that provide them. So I will try to prescribe newer therapies when I know that we've exhausted all of the other therapies. And then I'm a huge advocate of psychotropic genetic testing. You can see what medications your bodies are going to process and either have effect on how you process it, meaning that if you underprocess it, you're going to have a high amount of drug in your system. If you overprocess it, you're going to have a low amount of drug in your system. And then identifying gene drug interactions within there. It can be useful, and it can also save a lot of time. There is a cost associated with that for most insurances, though.
But less trial and error, which that
Yeah, you
sounds
save a
much
ton of
better.
time. So if you have a commercial insurance, some of them will, you'll pay a portion of out-of-pocket expense, but it's usually like making sure it's medical necessity, or some insurances are just more challenging than others. But yeah, there's a lot of different treatments for depression.
Different medication, different types.
Yeah, and I think you actually just hit on this. We're just discussing the stigma. A lot of people don't want to take medication for depression. It almost feels like it's like a defeat, like you've lost the game and you're weak or something like that.
All the time. People will say, I just want to do this myself. I'm like, well, you are doing it yourself. Like I don't need help. I want to be able to do this. And so I do have to often encourage people that this is not giving up. This isn't you're just letting the medication do it. You still have to do stuff. It's not going to just, it's not a magic pill. It's not going to make you, everything perfect, but it's an uphill battle with some people if they don't have medication on board. And the same with anxiety. But if I diagnose a client with depression, I don't automatically say, okay, now go get on an antidepressant. I will instead first see if we can use some interventions to help decrease their symptoms. And if not, then that's when I have a talk with them. Like, listen, I think we've been trying this long enough, or, that I think we could just use that on board. It's going to make this all much easier. But some people are very, very resistant to it. And I've had people leave. Like, everybody always just tells me to go on medication. And I, won't tell them that initially. But then afterwards, I'm like, yeah, I see why they're telling you this, because you need it.
Yeah, and I'm the polar opposite with that, with recommending therapy. I recommend everyone get therapy. And some people don't want it for whatever reason, but I love that because there's not side effects from that. That's not tolerated.
Yeah, it was no offense to you that I don't refer.
I know, I completely understand that. And again, it's because like people think antidepressants will change your personality, or they're just a quick fix, and they're not going to address the problem.
And that's not true at all.
No. And part of that within there is that sometimes people will stop taking a medication because, like you said earlier, that it doesn't work fast enough, or it stopped working. So they stop taking it and it's detrimental. There are ways in which you come off of a medication.
Yeah.
And it's usually stepwise. You do that with a professional.
I've seen people make all kinds of systems, like without asking the prescriber first, and they'll be like, oh, I'm taking it every other day, or I'm cutting it in half, or whatever, and it always makes me nervous. But the other thing, do you have people who want to stop taking their medications because they're feeling better?
Yeah.
And that it could be that they're better, but it also could be they're feeling better because their medication is making them feel better, and then they stop taking it, and then they end up
1000%. And I think it's not uncommon. And I tell everyone, any of my patients, if they want to come off of medication, we do it in a stepwise approach to make sure that you're not going to have that cold turkey experience and then be back where you first started. But there's a way in which you can do it. And I think if you have a good working relationship with your prescriber, it's just the same way in which someone would want to end therapy. Like, you would recommend whether or not you think that's a good idea, because some people are ready. Some people, it's a temporary relationship, and that's good. Even for some medications, like if you were just going through a rough time, and say, for instance, you didn't have a job, you were homeless and all that stuff, and then that resolves, and then you're in a better place. That's the time to do trial weaning down a medication in a process that's safe. The big thing for me is safety. It's not safe to just stop a medication because you don't know exactly how it's going to impact your mental health or physical health, for that matter.
And if you want to scare your therapist, then all you have to do is tell them that you are just stopping it.
Yeah, so I think we did talk about some of the common challenges with therapy, medication prescribing, misconceptions as well. When the symptoms are beyond their own self-management, where it's interfering with life, like you said, and it's not a matter of defeat, it's just getting help. You would get treatment for high blood pressure. You would get treatment for diabetes. It's twofold. It can be biochemistry, but it can also be mental health in and of itself. They play parts together. So I think knowing that there's a place for medication and for therapy, and if you want to escalate in a stepwise thing, first, like you said, start with therapy, add medication on if you need. You may want to consider a little more support with your depression.
Exactly. And it's not always mind over matter. And that's why medications work, because you can't think yourself out of a depression sometimes, just like you can't think yourself out of heart disease, right?
I've had a number of patients who started off on medication and continue them forever, and not a problem. I've had a number of patients who start medication, say, hey, I want to come off this. Sometimes medications do change the way in which you feel and the way in which you think, and you can feel a difference. Now, again, sometimes that can be better, But the idea is that you weigh the pros and cons of being on it and really just see like, was this something that I needed temporarily, or are these things in play and I still need to take them? But again, that's a discussion that we have together and sort out, is this an appropriate step? Do it safely and then go up or down, go down and then go back up if we need to go back up, or go down to off in a safe manner.
And all the medications that you mentioned, the SSRIs, the SNRIs, the atypical antidepressants, none of those are like lorazepam. You say it better.
Lorazepam.
Yeah. None of those are like that, meaning they are not, you take it and then you feel better. These are all, you have to build it up in your system.
Yeah.
And so people, I know they ask me like, well, am I going to be different? How am I going to act? I don't want to not feel like myself. I don't feel like it's really like that with these kinds of medications.
Yeah, some people will say they do develop numbness, and that's what can happen. So there is no emotional variation. Like
They can't cry. Sometimes I'll.
so there are some instances in that. So, but that's really, if we knew if how you were going to react when we took a medication, we would prescribe the right medication from the jump.
Right.
So I think that's the part of it. So our final thoughts in terms of unipolar depression is that depression is treatable, and that we can use both therapy and medication to help improve outcomes. And this oftentimes, the earlier you treat something, the better the outcomes can be sooner. Anyway.
There are lots and lots of books and other podcasts and such. I would definitely recommend Feeling Good by David Burns, and I would recommend The Happiness Trap by Russ Harris. I recommend those all the time. I don't recommend a lot of books to my clients because I'm kind of picky about that for some reason, but I do recommend those two on a pretty regular basis. So any other final thoughts that you have, Dom?
Yeah, we probably should have mentioned it, but there are crisis lines that are available called 911 or 988, particularly when you're feeling really down and suicidal. I say that to everyone, particularly with med changes too, that if something escalates to a place of where you have a drastic shift in mood, you don't feel right, you feel like something's off, you can call those numbers, or I tell people to make sure they have a support person available. These are things that are not likely to happen, but can happen. But just knowing that you have resources available, if anything does happen with any med changes, coming up with a safety plan, those are things I like to do. I review them and I make sure that people have a verbal understanding that this is what we're doing. Medications are likely to help. In the off chance this does happen, you have a safety plan, and that unipolar depression can feel really lonely. So there, in addition to just regular one-on-one personal therapy, there is group therapy available. Well, and then the last thing would be is that I'm super excited that there's always new treatments that are coming out. We've had a lot of success with some of the older medications, but for people who haven't found the right med yet, that it still may be out there to be developed. So super exciting.
That's very encouraging. Yes.
Yeah. And then lastly, as we always say, if anyone has any comments or thoughts or questions or anything they'd like to contribute to the podcast, feel free to contact us via the podcast site at www.lslpodcast.com. And that has our information, our practice information, and places where you can leave comments, get in touch with us.
Yes, we would love to hear from you.
So I am Dominic Marano.
And I am Katie Brzozowski.
With the Long Story Longer podcast. We hope that you learned something about unipolar depression and get some treatment if you need it.
Yes, bye.